The journey of caring for a loved one who is living with dementia can be quite challenging. The aim of this podcast is to make caregiving less daunting and more fulfilling. On this platform, we share knowledge, understanding, and experiences. We enlighten, give hope, and encourage, and in the process, create positive awareness about different aspects of dementia. Welcome to my podcast, Dementia Caregivers Corner. My name is Juliah. Dementia Care, how deep is your love? In today's episode, I am joined by an economist working at the Office of Health Economics in London, prior to which she completed her PhD in Health Economics from the University of Sheffield, where she investigated health-related quality of life assessments for use in dementia economic evaluations. She's also a pharmacist by background and have a special interest in dementia and related research. Ladies and gentlemen, let us welcome in today's episode, Dr. Hannah Hussain. Dr. Hannah, I welcome you to Dementia Caregivers Corner Podcast.
Hi, Julia. Yeah, thanks for inviting me to talk today.
Yes, I was looking forward for this. First thing first, I came across your work through an article that you wrote on the Dementia Researchers website. And like I said earlier, I read a bit about your background from there. And I was intrigued by that. Like, oh, okay, there's this person here whose background is in pharmacy, but now she's interested in dementia-related research. And I wanted to know why. What piqued your interest? Why the shift, if I may call it that way, or the transition?
Yeah, no, that's a really good question. So I started my education studying pharmacy at the University of Nottingham. And it was during my studies there where I became first interested in health economics and the broader impact of health care decisions on patient outcomes. And then retrained as a health economist. And that's when I worked in the area of dementia first. So I worked on the SenseCog trial, which is a large multinational trial that looked at a non-pharmacological intervention for people living with dementia and their caregivers. And that's when I first got inspired and interested in the area of dementia research. And that was actually during that trial that inspired my PhD topic, which focused on integrating self and proxy reported health-related quality of life in dementia for use in economic evaluation. So I'm very much on the economic side of dementia. But during my PhD studies, it allowed me to explore different aspects of dementia as a condition, including how dementia care is delivered. So I guess all the pieces just fell into place, and that's why I'm here today. And I'm really keen to stay active in the field of dementia research. So, yeah.
That is really interesting, Hannah. One of the articles that you wrote titled Challenges Faced by the BAME Communities in, I think, accessing the dementia care. I want you to define what BAME communities are and highlight the importance of the need for them to be catered for.
So the acronym BAME stands for Black, Asian and Minority Ethnic Communities. But I think we actually need to move beyond this kind of broad, simplistic term because it lumps together a vastly different group with different cultures, different linguistics, different socioeconomic challenges. So, like you said, just highlighting their experiences in dementia care, it's really important, especially in the UK. We live in a very dynamic and kind of diverse population. So it's, the way that kind of care and treatment is delivered in the UK as a standard is often a one-size-fits-all design, which doesn't really work for diverse communities like we have here. So I think that there needs to be a change and acknowledgement that actually the UK isn't just white. We do have a lot of different communities and a lot of different backgrounds here, and we need to start integrating and thinking about how to serve them too.
The other thing is I've read that the BAME communities in most instances are diagnosed later, or some of them are not diagnosed at all. So I'm here thinking, what should we do? What do you think are the barriers that make it harder for the BAME communities to have a timely diagnosis, an accurate one even for that matter?
I think there's kind of like an interplay of different factors that would impact someone's dementia diagnosis specifically from these communities. So there's challenges with cultural perception. So sometimes it might be that these symptoms are just kind of not recognized as dementia at all, often seen as a symptom of old age, which carries a lot of kind of shame, judgment, and indeed stigma. So, there's that kind of cultural perception. There's also language barriers. So, standard kind of cognitive tests aren't always translated or culturally adapted. So, there's that aspect of the language barrier, but also just at the point of communication between a person and their healthcare provider. So, at the doctor patient relationship, there's also language aspects that I think are really important. And then there is a kind of unsettling and real thing that we probably should touch on, which is that professionals don't always fully engage with the concern of minority families, which can lead to misdiagnosis and underdiagnosis. And there are implicit biases in medical decision making, which does mean that it is more difficult for minority patients to receive proper care. There's actually known disparity in the number of referrals that people from BAME communities get to specialist assessments and compared to white counterparts. So that can lead to later diagnoses. But I think just on that, if you don't mind if I just talk a bit more, there are kind of issues rooted in research. I'm a researcher, so I tend to see things from a research perspective. And most studies still recruit primarily white participants. So the guidelines and diagnostic tools and interventions that are being developed on the basis of this data that doesn't fully reflect the experience or symptoms of different populations. So this can lead to assessments that are less accurate and less relevant for minority groups. So to address this need, as well as all of the other things, and there's just so many, we need to make a better effort to recruit diverse and representative populations in dementia research so that our guidelines and assessments and treatments can be equitable and inclusive as well for these communities.
Where I've come across your work, I've subscribed to the newsletter for the main reason of wanting the voices of other non-white people to be heard. So as and when there is a research that is ongoing and they send the email, and if it's something that is for non-white or the BAME communities, I just jump in there for that reason.
Yeah.
Okay, you're talking about the language. Do we have organizations maybe that translate some of those assessments that you're talking about, the tools, into other people's languages from English? Do we have organizations like that?
I mean, it would really depend on the tool that's being used, because often with these tools, they're licensed. So actually making adaptations, you have to seek permission to do that. So they should be translated into the relevant languages when applied. But even beyond just kind of language, they also need to be culturally tailored. So just as like a kind of side comment, for example, some cognitive tests will have naming of animals and recognition as a kind of symptom of cognitive impairment. And I know loads of work's been done in this area to try to address these challenges. But if I just think of, say, for example, my grandma or an older person from a South Asian community, they may not recognize a dolphin, for example, not because of their cognitive impairment, but just because they've not encountered this animal. So, yeah. And also just something anecdotally that's come up through research that I've been doing in a different area, actually, but related to cultural biases. Sometimes people from different communities have different kind of thought processes altogether. So we use a scale in EQ5D. It's called the visual analog scale, which rates health from 0 to 100 with increments in between where you're meant to kind of select your level of impairment. Just some work that I've been doing, interviewing participants in Japan, indicates that their thought processes are more binary. So rather than these scale parts reflecting varying degrees of health, if they have an issue, they see that as 0 straight away. So these standard tools, they don't always work well in all countries and all cultures. So yeah, I don't know if there are specific organizations, but I had a conversation just with a colleague actually recently at a conference, and we were talking again about the EQ5D instrument. It's kind of fundamental in health economics research for measuring quality of life. And they're doing research here in the UK, and its translation is validated in both Urdu and Punjabi, which are two languages spoken in Pakistan. However, a large majority of the migrants from Pakistan to the UK don't speak either Urdu or Punjabi. They speak Mirpuri because they come from the Mirpur region. So the way that language functions, not in the Western world, but the dialect don't function the same way that English is spoken as a language. So I think there needs to be more awareness of that, because if we want to be able to detect changes and we want our instruments to be sensitive to this, they need to be appropriate for all populations. So yeah, I hope there's organizations that can do that, but I honestly don't know.
Yes, I think, again, as long as we make those instruments in English, even just to translate them, to find the right word, just take for an example, in my language or some of the sub-Saharan African languages, there's no equivalent of the word dementia. Just from there,
Yeah,
we call it a lot of things. Again, when you're mentioning the language, I had a guest from Australia. She trains dementia caregivers, and she said she had a client, someone who lives with dementia, who was in a care home, and no one knew the language she was talking. She said she came from Poland, and there was no one to cater for her needs, because dementia will take you back.
exactly. Very important.
I had another guest from South Africa. He takes care of her grandma who lives with dementia in South Africa. And I asked him, so should your grandma reach the later stages of dementia, would you take her to a nursing home? And he said, no, that's not how we do things. That's not in our culture. The societal expectation. So the question that I'm wanting to ask you is, how do we encourage someone from the BAME communities to use the services that are available? Because dementia caregiving can be a burden, really. How can we encourage them to use the services that are available to them?
Well, there needs to be kind of an intrinsic level of awareness in these communities. I think that it's really important. I mean, we do associate BAME communities with really strong family networks. And just like you said about your colleague from South Africa, they, in a kind of hierarchy where we very much respect our elders, to put them into a care home is something that we would almost see as shameful. So that's one side. But I think there needs to be a greater awareness and culture around understanding and appreciating burnout and financial strain, particularly in today's economy where most caregivers are going to be juggling a full-time job. So there needs to be better respite options, and that can sometimes be day dropping services where you know that your person is going to be cared for, you know that you're going to be able to provide better care when you come and see them again, you know that they're going to be engaging with other people and it's a proper service. But again, having these to be culturally adapted, knowing that your loved one is going to be able to eat the right food that they would usually eat for lunch that you're not able to give to them, and they're not going to feel isolated. And there is someone there that speaks the same language, and they're not going to be forced to do exercise activities that they wouldn't usually do at home, or listen to music that they don't listen to. Of course, we in the NHS would be completely bankrupt if we did not have informal carers. We are relying on formal carers. So, better financial support, better allowances for carers is something we could always advocate more for. And then, even at the employment level, having more flexible kind of employers, so that taking an awareness and an understanding that these people are carers after hours too. So, yeah, I think like anything, and like most of the things we're probably going to talk about, it needs to be targeted to be able to reach these communities and help people in BAME communities to manage guilt, association and stigma, so they don't feel bad. If they do want some respite and time to themselves, it allows them to be better carers, better children, better parents, better spouses. So yeah, there needs to be more done. I wish I knew the answer how. We need to connect with people in public health and encourage them more.
Yes, I wish that could be done. There was some research again that I read that said dementia caregivers face more stress and burnout compared to caregivers of other illnesses. So really, we need this information to get out and reach them. You talked about the unpaid carers. I was going to ask you that question later on, but let me just get into it. I think one of your articles, the articles that you wrote again on the economics of dementia, where you're talking about direct cost and indirect cost. Yes, you've already mentioned some of those from there. So let's talk about the unpaid carers. You actually have mentioned that they do save the NHS money, but what can be done more to support the unpaid carers?
Yeah, so definitely the NHS will be burnt out with unpaid carers, not just in dementia care, but dementia care is so critical because even though it may not be at the level of the nursing home, just having to supervise, constant supervision, not knowing if your loved one is going to be safe through the night because not knowing if they're going to, have some kind of impairment. So it's not just necessarily nursing home support, but it's also this kind of heightened awareness that this person has to carry with them at all times, just ensuring the safety of their loved one. So yeah, that can lead to a lot of burnout. And like we've just mentioned, the NHS would not be able to be financially sustained without it. So I think the issues in this area are not just related to BAME communities, but like we mentioned before, just having better financial support and better allowances and an acknowledgement that the healthcare system wouldn't otherwise function. So we should be adequately reimbursing these carers for the support and service that they provide. And then flexible working policies for carers. The carer shouldn't, in a perfect world, feel pressured to come and do a shift at work if they've been up through the night providing support. That's a recipe for burnout, and that is ultimately what's happening. So there needs to be kind of financial benefits and financial support, but we're living in a time of resource constraint and everything and everywhere needs this. So yeah, it's hard to say what tangibly needs to be done, but more needs to be done for sure.
When you're talking now, I'm just thinking of this lady that I assisted to care of for her mom who was living with dementia. So I'm imagining her moving, maybe trying to go to work and then coming back to the mother, how hectic that was for her. The mother died last year. Jenny, may her soul rest in peace. Yes, but what really happens, the hectic part of it, where you don't even, you can't rest, because dementia is like an ongoing, whether it's day or night. Someone who lives with dementia, really, they go through a lot. I wanted us to talk about the stigma. I don't know, we experience stigma differently. The white people experience it differently from the way I experience it. Where I'm coming from, we isolate people who live with dementia. We think they are mad because we don't know what dementia is. And like I said, I didn't know what dementia is until 4 years ago when I came to the UK. How do people in your community, is it British Asian?
Yeah.
How do they experience stigma? How does it manifest itself?
Yeah, I would assume there's a lot of similarities between how it would manifest in Asian and Black communities, but essentially stigma is often just seen as old age. Dementia is just often boiled down as old age rather than seen as an actual tangible medical condition. So that can delay families from actually seeking help and seeking support as well. They're just old. This is just how they are. But there's also a fear of shame and judgment and some worry that it may reflect poorly on the family. Are they not looking after their loved one? Or even a reflection of past sins, which comes to the kind of religious interplay with culture, seeing it as a kind of punishment for life past. So, lots of people might suffer in silence. They might not come forward and admit that they're experiencing symptoms of dementia, and their families might not come forward and admit that either. So, yeah, it turns to this reliance on informal care rather than formal support as well, weighting more heavily on carers just because of this stigma. So if we can do more to highlight that this is a real medical condition, this is an element of age, yes, likely is going to impact you more as you progress through stages of life, but it's a medical condition that's happening, and there are good drugs, there are good treatments, non-pharmacological interventions too that can help and support you and help to alleviate your symptoms, and see it as any other medical condition. But yeah, more needs to be done about that. So these people aren't just boiled down to, they're just old, it's fine, this is just how they are.
Yeah, awareness, it has to be robust.
Yeah.
When you mentioned non-pharma, how do you pronounce that word?
Yeah, non-pharmacological.
I get excited about that because where I'm coming from, there are limited resources to health. So anyone who talks about the non-pharmacological part of healing, I am really interested to hear more. Maybe something that can benefit our people as well back home. Let's then come to I want us to talk about the care homes in the UK. Do you think that they are well equipped to assist people living with dementia from the BAME communities?
My knowledge on care homes and functioning is limited, but I would assume that many care homes in the UK aren't equipped to support people from BAME backgrounds. So again, we've talked about language barriers, but you mentioned also before just about colleagues. I would assume that few members of staff speak community languages or diverse languages. I mean, caregivers are severely underpaid, especially in care homes. Social workers are severely underpaid. You know, they do God's work, but how much can we expect from them in terms of competency in those areas? I touched on this before, dietary needs. I wouldn't assume that in care homes they have culturally appropriate food or, you know, things that would suit different tastes. I would assume it's kind of set. And then also we touched on kind of the intertwining between culture and religion and spiritual needs. So, I think that this needs to improve. I think there needs to be more cultural awareness training and inclusive policies and indeed a recruitment of more diverse staff. Just like I think there needs to be more diverse researchers that can help to drive this research from the root. We need that in all areas, don't we, in order to ensure that all populations' needs are being served. So I think that they'd be the kind of main things that I would think of. I'm not sure in terms of restrictions with visiting hours and things like that, making sure that they're accessible as well for everyone. But yeah, I haven't worked that much in care homes, but they're the things I would probably think of first.
I was also talking to a guest who lives with dementia. He is in Namibia, in Africa. They have a care farm. It's a farm where they want to turn the village into a dementia-friendly village. And so he says to me, Julia, we cannot do the same things that you do there in the UK. We're totally different cultures. I'm not going to ask my people to dance. To dance what? You say, those activities. I mean, I was just laughing when you mentioned the dancing because this man is saying the same thing. Dance to what? We don't dance. We go out, you see. Yes, cultural appropriate activities in the care homes. But then I can guess maybe for like it will be expensive maybe for the care homes or whoever, even you guys, the NHS, to bring everybody on board.
Yeah, that's the reality. Of course, the majority population in the UK is white, but we have to acknowledge that we have, I mean, me, myself, I'm a third generation migrant of Pakistani parents, Pakistani grandparents. I would assume my children will be here. We still have culturally different needs. So the landscape is changing and there's a lot more kind of mixed race population. You know, things are constantly evolving and constantly changing. So yeah, I think it is expensive potentially at that level if we're going to consider each individual. But I guess that's why a BAME classification that kind of does organise people together. There are some comparisons, but again, there are differences. But yeah.
Yeah. And again, I'm thinking the trainers, do they train effectively, those who are training people for caregivers for dementia care? Because I hear a lot of now, we just trained on the basics. We don't know how to handle that. Maybe the type of dementia, we don't know how to handle that. I'm thinking about the trainers themselves.
Yeah, exactly. I mean, like we mentioned just before, they're vastly underpaid services and vastly unacknowledged services. So if we just take a kind of wider lens on that point, how much can we assume is going into training and care? How much can we assume is just learning on the job as well? So yeah, it's one of those dark areas that I think more needs to be done, really.
We need you. We need you to continue with those researches so that we can change the policies.
That's it. That's what we need to do.
I want us to talk about the scientific and social research. I want something that will obviously benefit the people from the low and middle income countries, you know, they're not non-pharmacological. What is wrong with me with that word? pharmacological.
Yeah.
Tell us, what would benefit them more in terms of, do they need scientific research more than social research, or it does not matter? Something that will benefit them, those who have no resources.
Yeah, that's a really good question. I think, of course, resource constraints are really important. We mustn't underestimate that, though non-pharmacological interventions are different in their approach. The trials often cost a lot, which does make it very difficult to prove their cost effectiveness in terms of their interventions.
Mm-hmm.
So they can also be expensive, but potentially easier to administer. Or more direct to administer, as opposed to kind of going through pharma regulations and pricing policies and stuff. But just back to your question, I think both scientific and social research are really important and crucial for immediate impact. So in terms of like scientific research, it's often already global, but social research is more direct by looking at barriers to care, stigma, policy gaps in specific communities. In terms of low and middle income countries, investing in awareness campaigns, as you know, like you mentioned in your language, we don't even have a word for dementia. So having those awareness campaigns at the root level, early diagnosis programs, and support networks for carers where they can come together and learn from each other, I think can be faster and tangible improvements in dementia care from that kind of lower baseline. But we can't ignore the scientific impact. And one thing that I think is really interesting that's been growing in traction and recently in the scientific community is epigenetics, and highlighting how genetic expression is influenced by environment and lifestyle, but also by your background and your ethnicity. So we already know, just to relate it back to South Asian communities, we already know that South Asian women experience menopause earlier, and there's a higher prevalence of PCOS. And diabetes rates differ across ethnic groups. So there are biological variations, which suggest that there could be different pathways in dementia too. Yet the research in targeted ethnical differences is lagging. So what do we get as a result of that? Again, a one-size-fits-all approach in dementia research, in drug development, in treatment guidelines, and they may not fully address specific risks and needs in these diverse populations. So, yeah, I think in order to improve outcomes, we need both, which is maybe a cop-out answer, but we need both social and scientific research evolution in those areas, and understanding like barriers to access to care as well. So, yeah, it's a bit of an everything approach, really.
The last thing, is there anything that you would have wanted me to ask you that will benefit our people that I did not ask?
Yeah, that's an interesting one. I guess if there are people from BAME communities that are listening to this, or indeed people not from BAME communities, what do you think you can be doing, and how do you think we can access your loved ones? Because we as researchers and as informed people, we can often take a step, a kind of step behind, and we can read the literature and read the research and try to think and try to impose. But what are the tangible barriers that are happening in your day-to-day life that you think we could make improvements in? Just at a kind of access level. So yeah, I guess the question I would ask to listeners about the experiences that they've had or heard about are, what's stopping people from getting access to care? Because you are entitled to care and support in this country. It is made available, we pay taxes, and that's what it's there for. So other than these kind of higher level stigma concepts, what are the other things that we can be doing more to support these communities in? And just being able to integrate them into kind of stakeholder engagement and at different levels would allow us to think about how to address these questions in policies going forward. So yeah, it's a difficult question really, but I think that's what we would want to know and learn more.
Yes, and I agree with that. No, let me take this time to thank you very, very much. I'm just excited talking about anything dementia related. It just gets me excited. So thank you very much, Dr. Hannah.
No problem. Thank you so much for having me. It was great talking to you.
Let me take this time and thank you, our dear listeners, for tuning in to this episode. If you have enjoyed our conversation or are passionate about dementia care, please consider leaving a review and sharing this episode with someone who might benefit from it. Your support helps us reach more people and raise awareness about dementia-related issues. Until next time, take care and bye for now. Ta-da! Dementia Care. How deep is your love?